Our topic today is cervical spine injuries. The incidence of cervical spine injuries ranges from 2 to 4% of all injuries in orthopedics. However, it poses a significant socio-economic problem due to complications and sequelae related to involvement of the spinal cord. It is usually associated with high energy trauma that can occur in motor vehicle accidents, sports injuries, diving injuries, falls from heights, and even rarely gunshot injuries. To understand the mechanism of injury and methods of treatment, a review of certain points of the anatomy is necessary. The upper cervical vertebra C1 and C2 are unique and are specifically designed for flexion, extension, and rotation. Below C2, below the axis, the subaxial vertebrae have a different set of characteristics, as we'll see later. The first cervical vertebra, the atlas, has no central body. It is simply formed of a ring of bone with large lateral masses. The posterior ring is quite thin, just posterior to the facet joints due to a depression for the vertebral artery. The second cervical vertebra, the axis, has, on the contrary, the largest body of the cervical vertebra. It has a superior projection called the Odontoid process, which is stabilized to the C1 ring. The upper cervical spine has a complex ligamentous anatomy to maintain its stability. There are 5 ligamentous structures that include the anterior Atlanto-occipital membrane, the apical and alar ligaments, the ascending band of the cruciate ligament, and most importantly, the transverse atlantal ligament, which is the main stabilizer of C1, C2. It can be as thick as 1 centimeter. The subaxial vertebra from C3 to C7 all have a similar appearance. They all have a body, a pedicle on either side, a transverse process in which the foramen for the vertebral artery is enclosed, superior and inferior articular processes, a lamina, and a spinous process. To diagnose injuries of the cervical spine, we start by plain X-rays, which are usually the first imaging studies performed. The lateral view can identify most fractures and dislocations, and it's very important to visualize the C7 vertebra to detect cervicothoracic injuries. It's also very important to delineate the 4 contour lines, one anterior to the vertebral bodies, the other posterior to the vertebral bodies, the third at the base of the spinous processes, and the fourth at the tip of the spinous processes. If there is any interruption in any of these lines, this can detect an injury to the cervical spine. The open mouth view is very important because it provides full visualization of the odontoid process, body of the axis, lateral mass of C1 and C2, and the atlanto-axial joints. CT scanning is becoming the gold standard for the diagnosis of cervical spine injuries because it is more sensitive than plain X-rays in their detection, with a sensitivity of up to 98% versus 52% for plain X-rays. MRI is also very important. It can show associated disc herniations, injury to ligamentous structures, spinal cord injuries, and changes in the cord intensity on MRI may help predict long-term prognosis. On the other hand, MRI requires time and is not always available in every institute. Neuromonitoring is very important to confirm the diagnosis of complete spinal cord injuries. It's also recommended during closed and open surgical reductions of the cervical spine. These patients must have a full neurological examination that includes a sensory examination for each and every dermatome, a full motor examination, and you have to know the root value of each and every muscle. And when examining for motor power, you have to be not confused with the flexor withdrawal reflex, which is commonly present after complete physiologic cervical transection. The patient must be able to voluntarily contract his muscles. Rectal examination is also very important, whether sensory examination or examining the tone of the muscles, and it's very important to test for the bulbocavernosus reflex, which delineates the end of spinal shock. All of these data must be included in the patient's neurologic sheet. And now we'll go through these injuries one by one, starting from above downwards. We'll start by occipital condyle fractures, which were classified according to Anderson and Montesano into 3 types. Type 1 is a comminuted impaction of the condyle. Type 2 is associated with a basilar skull fracture, and type 3 is an avulsion of the condyle. These patients present with pain at the base of the skull. They may be accompanied by head injuries or fractures of other cervical vertebra. They present by a tilted and rotated position of the head that resembles a rotary subluxation disorder, and they should be suspected in patients with cranial nerve defects. Because of the location and rarity of these injuries, they are difficult to diagnose, and you will need a reformatted multi-slice CT scan to be able to detect these injuries. Treatment of type 1 and type 2 is conservative because they are a stable injury. They need 8 weeks in a half collar. Type 3 are potentially unstable and they need a halo vest to provide more rigid immobilization. And now we come to a more catastrophic injury, occipito-atlantal dislocation, otherwise called craniovertebral dissociation. This was historically only reported as occasional case reports, but recently, with the advancement in first aid, survivors are more frequently met. They account for 20 to 30% of deaths from cervical spine injuries and, of course, are related to high-energy motor vehicle accidents. Patients usually present with severe neurologic injuries. However, there were some case reports of patients who were neurologically intact. They were classified into 3 types. Type 1, the occipital condyles lie anterior to the atlas. Type 2 are a pure distraction injury of the condyles without any translation. And type 3, the occipital condyles are posterior to the atlas. Of course, traction must be avoided. The goal of treatment should be to stabilize the head in relation to the trunk. By careful application of a halo and placement of a halo vest, any attempts of reduction should be undertaken with great care and, of course, preferably with fluoroscopic guidance. This is a pure ligamentous failure, and these patients require an occipito-cervical fusion for stability. Atlas fractures occur in 3 to 13% of cervical spine injuries. They occur through axial compression and are frequently accompanied by other injuries in the cervical spine. These are canal-widening injuries and are rarely associated with a neurological deficit. Patients usually complain of pain in the upper neck and a feeling of instability. They are classified into 3 types. Type A, where the posterior arch is fractured. Type B, when asymmetric axial force occurs, it results in a fracture anterior and posterior to one of the lateral masses. And type C, if there is a symmetric direct axial compression, this results in fracture of the ring in 3 or 4 places, the classically called Jefferson fracture. The central issue in determining stability is whether the transverse ligament is intact or not, and there are possible methods for determining its integrity. The most simple method is finding an avulsed fragment at the insertion of the transverse ligament on the CT scan. If you have a sum of displacement of the lateral mass overhanging of a total of more than 6.9 millimeters, if you have an Atlanto-dental interval ADI on the lateral cervical spine of more than 4 millimeters, and you can directly visualize the transverse ligament with MRI. Stable fractures are placed in a cervical orthosis. Unstable fractures need rigid halo immobilization. Operative treatment is indicated if there is a non-bony avulsion of the transverse ligament or if there is residual instability after immobilization, and this includes occiput to C1 and C1 to C2 fusions. Fractures of the odontoid process of the axis are the most common fractures of the axis. They present with only pain, which makes their diagnosis quite difficult. They are quite oftenly missed, and you need CT scanning with multi-plane images or a very good quality open mouth AP X-ray. Anderson and Alonso classified them into 3 types. Type 1, this is an oblique avulsion fracture of the upper portion of the dens. Type 2 occurs at the junction of the dens with the central body of the axis. And type 3, the separation occurs in the body itself. Type 1 are stable fractures, however they may be associated with other injuries. In the absence of ligamentous instability, a cervical orthosis is all that is required. Treatment of type 2 remains controversial because there is a high rate of non-union, up to 36%, and this is because the base lacks either periosteum or cancellous bone, which results in a relatively poor blood supply. And also non-union can occur due to distraction forces applied by the intact alar ligaments. The higher risk factors for non-union include age in patients over 50 years, and if you have a displacement of more than 6 millimeters, or if you have posterior displacement. Surgical options include anterior screw fixation of the odontoid or posterior C1-C2 fusions. Type 3 are typically treated with a halo vest with bony union rates ranging from 84 to 100%. Non-union is high if there is displacement of more than 5 millimeters or angulation of more than 10 degrees, and in this case, surgical stabilization is indicated. Hangman's fracture was first described in convicts who were executed by hanging, and it was first classified by Effendi into 3 types. Type 1 with displacement of less than 3 millimeters and no angulation. Type 2 where the displacement was more than 3 millimeters, and later Levine added a type 2A where the C2-3 disc is avulsed. Type 3 is quite rare and it has an additional unilateral or bilateral facet dislocation. Type 1 are stable injuries and are placed in a cervical orthosis. Type 2, you can either position them in a halo vest for 12 weeks after reduction, or you can surgically stabilize them. But types 2A and 3 need surgical reduction and C2-C3 fusion. Lower cervical spine fractures were first classified by Holdsworth in 1970, and there were several classifications along the years, including Allen's in 1982, Dennis in 1984. Max A.B. had the AO classification in 1987, but finally Alexander Vaccaro and his study group published in 2007 the Subaxial Cervical Spine Injury Classification System, otherwise called SLIC. It relies on 3 major injury characteristics: the injury morphology, the integrity of the discoligamentous complex, and the neurological status of the patient. Within each of these 3 categories, subgroups were identified and graded from least to most severe. Morphology was either compression, distraction, or translation, discoligamentous complex integrity as determined by the MRI, and the neurological status of the patient. In each category, the patient received either 0, 1, 2, 3, or even 4 points. Surgical versus non-surgical treatment was determined by the total score the patient had. If it was from 1 to 3, non-operative treatment. If the patient had a score of 4, this was a gray zone with either operative or non-operative treatment, and if the patient had a grade 5 to 10, operative treatment was indicated. And now we'll describe 2 of the most commonly met injuries: uni or bilateral facet dislocations. Unilateral facet dislocation represent 6% of all cervical spine injuries. They are most frequently missed on plain X-rays. They lead to a subluxation of 25% or less, and 20% of patients have an associated neurological effect. Bilateral facet dislocations lead to 50% or more subluxation on X-rays and are often associated with significant spinal cord injury. The goal of treatment is to reduce and stabilize the injured segment. 40% of bilateral facet dislocations have an accompanying herniated cervical disc, so you have to perform an MRI before reduction. If there is no associated herniated disc, you can go from the back, reduce and stabilize, but if you have a herniated disc, you have to go from the front first, take out the disc, and then reduce and stabilize the spine. Burst fractures result from high-energy trauma. They usually have compression on the spinal cord and are usually treated by anterior reconstruction. The most commonly used operative techniques in the cervical spine include anterior screw fixation of the dents, C1, C2 transarticular fixation, whether from the back or from the front, C1, C2 fixation by Harm's technique, including polyaxial screws in the lateral mass of C1 and in the pedicle of C2, Judet technique for the reduction of Hangman's fracture, and actually we published this technique in 2010 in type 2 Hangman's fractures, and lateral mass fixation. Anterior cervical decompression is very useful in facet dislocations and in burst fractures. You take out the disc or perform a corpectomy and then reconstruct the spine, whether by PEEK cages, expandable cages, or titanium mesh cages, and fix them by a plate. So cervical spine trauma is a common problem with a wide range of severity, from minor ligamentous injury to frank osteoligamentous instability. Proper management aims to identify these injuries, detect the pathology, classify the injuries, predict instability, and provide adequate treatment. Thank you very much.